get started. Um, Welcome to the pre-Turkey Sports Medicine Grand Rounds. Today we have two lectures. The first is going to be given by Dr. Hank Helto. Hank was our fellow last year, and we have the privilege of having him be one of our sports medicine faculty now. One of his areas of interest over the course of his training and presently is in cardiopulmonary exercise testing in sports medicine, and he's going to be enlightening us on that topic today. So welcome, Hank.
Thank you, Ashwin, and thanks for everybody for being here. A couple of disclaimers before we start. I'm a family medicine doctor who on Monday saw like 15 colds and 10 there's a rash on my hand, so that's how I approach cardiopulmonary exercise testing. And as I was getting ready for this and have been studying it in the past, exercise physiology, cardiopulmonary physiology is an incredibly complex and diverse world. And so I'm going to talk a little bit about it, but get out of that realm a little bit and into some of the applications in sports medicine. And Dr. Lux is here, and this book was incredibly helpful for me to kind of synthesize this talk down a little bit. And so if anybody's interested, it's a wonderful little primer introduction to cardiopulmonary exercise testing that I assume is available, people can purchase. It's great if you're interested, and then maybe we can send Dr. Lux on a vacation somewhere with the royalties from there. To start off with a little bit of just background on cardiopulmonary exercise testing, and then I'm going to move much more, like I said, into the applications of it in the sports medicine world rather than talk about gas exchange too much, that kind of stuff. But the body's ability to adapt to exertion and even rest, but much more so exertion, is an incredibly complex system. And when we talk about it in the world of cardiopulmonary exercises, testing and exercise physiology in general, the three kind of big box systems that I think about with this are your pulmonary system, your cardiovascular system, and then your neuromuscular system. The pulmonary system is our ability to pull in oxygen, exchange it with blood, and blow off CO2 that we're going to generate as part of our energy creation system as we exercise and use our muscles. The pump is critical. None of this, the lung functionality happens without a big pump, which is our heart, and that's our cardiac output. That's our ability to turn over blood that's exchanged in the lungs. And then a system that is also very critical, but much less likely to be the source of any type of physiology or physiological issues is the muscular neuromuscular system. But that's where the meat of a lot of this happens. That's what is our driving force in terms of propelling ourselves forward and doing this work. And that's the oxygen extraction from the blood, and then the generation or the turnover of that into energy that we need to drive ourselves forward, and subsequently the release of the byproducts of that back into the pulmonary system for us to be able to blow it off. So there's a ton of parameters that get measured as we do cardiopulmonary exercise testing. And these are just a very small fraction of those, but a lot of them have to do with partial pressures of gases and volumes of the lungs and that kind of stuff. And again, I'm not going to get into this too much because it's complex and confusing. I think it's not exactly what we kind of think about and talk about in our setting of sports medicine physicians in this world. But I think it's important to realize how complicated and complex the system is, and to know that there are all these parameters that we can measure and talk about. So I'm going to go over CPET testing a little bit, talk about the interpretation of results, and also just the functionality of how we do the CPET testing. So if we're sending people, or you're sending people in, or recommend people that come in, what are they going to expect? What can they know about how they're going to get tested, what we're going to do in the system. And then the bulk of the time I'm going to try and spend on the applications of CPET testing. And I kind of try and break it down into things that I think we, as a group at the University of Washington Sports Medicine Clinic, as we kind of ramp up our ability to do this, are going to think about and talk about and potentially see people for, and what we're going to test them for. So cardiopulmonary exercise testing and is really the evaluation of how we extract oxygen from our environment and convert it into energy needed for work. And it's not an accident that a husky is beating a cougar in this race, because it's going to happen on Friday. That's right. But this kind of is where it all comes back to, is how do we take oxygen from our environment and convert it into the work that we're going to do? And this is the only equation I have in my thing. It's the Fick equation. Dr. Harmon, we're not going to talk about the citric acid cycle, Krebs cycle today. But I think it's important to look at this a little bit. This is a rearrangement of the Fick equation that we talk about in terms of how do we measure VO2 and VO2 max, which is really the gold standard for measuring cardiopulmonary fitness. And when we talk about VO2 max, that is our maximal ability to take in, transport, and use oxygen in our system. And that's the value as it comes into our system, then our ability to turn it over and turn that into energy. With VO2 is there, it's relying on your cardiac output as well as the difference between your oxygen and carbon dioxide concentrations in your blood. The VO2 max is simply that taken to the maximal level. So at max exertion, your cardiac output, your maximal arterial oxygen concentration, and your minimal CO2 oxygen, or CO2 arterial or mixed CO2 concentration. When we look at our cardiopulmonary exercise testing printout, and what we look at when we do these tests and get the results, this is a nine box plot, which is from Wasserman, one of the pillars of this world, and it helps us to look at patterns of gas exchange, patterns of cardiac output, heart rate, and things like that. And this is not a normal one, this is a slightly abnormal one, but the best one I could get to show up on a PowerPoint slide. And what we are able to do, and we see this, is there's very characteristic patterns of each of these types of these graphs. And as we start to see variations from that, those are highly suggestive of things like cardiac disease, pulmonary disease, or even neuromuscular disease. And so these kinds of graphic representations really allow us to pull out, if we're seeing something abnormal on a CPET test, what is that going to be? It's the same thing I just talked about. And we can all of these relate that back into our Fick equation and look at what these parameters might do to that equation and how those might relate to our inability to exercise, things like decreased exercise tolerance or other abnormalities in our CPET testing. Another really critical thing, kind of the last big box thing I want to talk about in terms of just background of CPET testing, is our anaerobic or ventilatory threshold. I just learned this more as anaerobic threshold, so that's the term I'm going to use. But it's really the point at which ventilatory threshold is another name for the same type of thing. And ventilatory threshold we use a little bit more, I think, in the UW pulmonology world, just because that's what we actually measure. We don't measure metabolic, or the anaerobic threshold is really a blood measurement, and we usually use ventilatory or oxygenation parameters. So, but they're essentially equivalent terms. But it's the point at which oxygenated blood flow just doesn't keep up with the metabolic demand of your exercising muscles or body anymore. It's roughly equivalent to when we develop lactic acidosis, and really more of a zone. So when you talk about your anaerobic threshold, we often will, and I think especially as we look at our computer programs and things, we look for an exact point in time, but it's a much more complicated series of transitions from your aerobic to your anaerobic predominant system. It's more of a zone that we sit and talk about, which is highly parameter and interpreter dependent. So as we look at each of these things, like on the 9-box plot, we start to see that there are variations in where we would draw this line for the anaerobic threshold, the ventilatory threshold. I learned this lesson when I was doing some testing last year, as well as that when it's interpreter dependent, you have to be careful. So we had a guy who came in and did a test with us, and he was irate that his VO2 max had gone down, but it had gone down by like 0.5 or something, and it was somebody completely different who had done the testing before. So it took us about 30 minutes to talk him down off the mountain, or off the ledge, that no, he wasn't, all his exercise or work had not gone to waste, but he was just, it might have been a little different of an interpretation of it. The VO2 max is often thought of in terms of how it relates to our maximal heart rate. And in a normal quote-unquote individuals, which is about 65, about 60% of your maximal heart rate. That can change a great deal depending on your level of fitness as well as your age. So people who are highly fit tend to have their VO2 max is at a much higher percentage of their maximal heart rate than people who are a more sedentary lifestyle. And similar for older people, so older age kids, the more likely your VO2 max is going to be closer to your maximal heart rate. And we'll talk a little bit more about that later, because I think that's a lot of implications in terms of how we counsel people about where their VO2 max is relative, or their anaerobic threshold is relative to their maximal heart rate, and how we can talk about training parameters for fitness and weight loss and things like that. So when we do a cardiopulmonary or CPET test, the most common ways we do it is on a treadmill or a bike ergometer. These are going to be the two modalities that we have initially over in the sports medicine clinic, and the two that we use most commonly over at the university pulmonary lab right now. They allow for a fairly normalized type of testing environment. They're easy to use. You typically do a ramp type of test with this, so you gradually increase the workload on somebody over time. A little bit easier to do that on a bike than on a treadmill. I think one thing that is a little bit different in the world that I'm going to talk more about sports medicine world, as we're saying now, relative to a cardiopulmonary disease world, is that it's really important to think about as you're counseling the patient on what kind of test you're going to do to recreate the environment in which they're going to be performing. And so if somebody's a rower, then setting them up on an erg is going to be a much more meaningful test and use of the interpretation of the test, is rather than putting them on a bike when they never ride a bike, they only row. Some people do swim CPET testing as well, or they put them in a pool and let them go. And so all those are a little bit more complicated in terms of how you perform the test, but in terms of its meaning for patients, I think it's really important. Another aspect of that I think is worth thinking about is that when we talk about testing people for a type of symptom, so at a certain symptom level they get fluttering of their heart or shortness of breath or something like that, it's really important to try and think about recreating that exact environment. So a sprint type of environment on the erg, something like that. So if you're not able to recreate that environment and you don't recreate the symptom, then I think you potentially are just missing what the person, what might be the etiology of the problem that they're having. A quick slide on just contraindications to cardiopulmonary testing, and most of this comes from our end when we do the test rather than somebody sending people into us, but things like acute ischemic events, acute COPD exacerbations, and heart failure are things that we typically will avoid testing during. Valvular disease, marked or certain levels of valvular disease, we also try and avoid it somewhat. Advanced AV blocks, tachybrady syndromes, advanced pregnancy, a lot of times we'll try and avoid these just because of the risk. So as I mentioned before, the testing is based on a ramp model. So there's several time points that we want to be really cognizant of when we do one of these tests. The first is at rest. So we usually do PFTs on a person at rest and then get some of their basic baseline heart rate, their gas exchange when they're doing nothing. And then we typically have them do some type of exercise, especially if it's on the bike ergometer, essentially a zero resistance type of pattern to their exercise. And it's important for that baseline data. It's also important, some people get really just pumped up when they start to do the test, and they're letting them do some non-resisted exercise often helps them calm down a little bit and get a little bit more meaningful parameters in terms of their respiratory rate and their heart rate. When we're on a bike, we'll often just progressively ramp somebody, so you go from zero resistance up to their maximal exertion and try and do it over the period of about 10 minutes. The way that you ramp somebody, the starting value that you use, the end value that you use, is highly dependent on the person that you're testing. So both age, fitness level, and what they do. Again, it's going to be different on a bike versus an erg, things like that. So we'll monitor them throughout their exercise, and then the post-exercise phase, I think, is important to remember, is a really, really important phase, especially for any type of arrhythmia generation that you might be worried about. there's a really high risk after somebody exercises that they have. That's where they'll kind of manifest arrhythmias. So we'll see that both symptomatically when people are coming in for certain reasons, but also when we are testing them. Really important to make sure that we're monitoring them after they're on. I mentioned before we do PFTs before we start any at their rest. Some of the other parameters that we just really make sure we have on everybody, you have to have a gas exchange mask. That's the whole functional aspect of CPET testing. And ECG is the standard that we'll use here. It's interesting. When I did my training in this last year at a different community place, they just do gas exchange. We wouldn't do any type of ECG monitoring, which is I think misses a lot of potential things in terms of what we're looking for, but is of a value, more value in a disease model than in a healthy population. I think critical to use anyway. Blood pressure monitoring is important, progressive throughout the testing. And ABGs are something I didn't do much of when we did our testing in healthy populations, but if you're really worried about dyspnea on exertion, you're worried about a pulmonary cause, and often ABGs are important to do through the course of your testing. You can do that either with serial sticks, which is, I've never tried it, but I can't imagine. It's hard to do a blood pressure with somebody running. I can't imagine doing an ABG with somebody running, but you can put in catheters and serially draw from them. And then, we would often be reminded when I was doing my training with an exercise physiologist, we get so enamored with the computer, and we're looking and watching parameters and watching things ramp and seeing where the ventilatory threshold is and when somebody's at their VO2 max. And you get an incredible amount of information from just watching a person, and you don't want them to end up on the floor like this, but also you get a lot of information about where their maximum is, when they cross thresholds, just by watching the person, watching their breath, talking to them about how they're feeling. So to transition a little bit more into applications of this, the exercise clearance is the first thing I want to talk about. And traditionally, exercise clearance, when we talk about this, is more of a stress, is purely cardiac stress test, and that's really meant to be a determinant of a potential ischemia or potential ischemia in a person who's going to start exercising. It is a well-founded reason for doing testing. Exercise is beneficial in essentially every possible situation, but sometimes people need more evaluation before they can do that exercise safely. I find this to be kind of an interesting, again, putting my primary care hat on, the idea of just testing somebody for their fitness to exercise. I'm not that experienced in the world of medicine, but far more commonly in terms of people coming in to see me and asking me about this stuff is they have tried something and something's not right. So somebody's exercising, they can't get up. Rarely have I seen somebody come in and just really say, hey, I haven't exercised in 30 years and I want to start exercising. Is it safe for me? I think that's less common, at least in my practice, than somebody who said, I'm starting to exercise and I can't do what I want to do, or I've had XYZ symptoms in the past and I was worried about them, and that's why I stopped testing. So I think that to me is an interesting application of CPET testing in terms of clearing somebody to really start an exercise regimen. So if it's purely somebody who's coming in saying, I want to think about starting, I want to get into exercise, but I have XYZ risk factors, or you're seeing that person in clinic, I'm not sure you need to CPET them. I think an exercise, pure ECG exercise test is reasonable. But if it's this more complicated system where they're having symptoms, they're having some specific concern, and I think CPET is an interesting application to be able to fully assess, as we talked about before, the three big boxes of their neuromuscular function, their cardiac function, their pulmonary function, and making sure that each of those parameters is adequate and safe for exercise. The exercise tolerance evaluation, I think, is another important place to think about CPET testing, and it's something that I think our primer book talks a lot about in terms of something that's just overlooked. So are you just getting this thought of, I think we see this a lot of times when we talk to people about our tendons and joints too, is that are you just getting old? Is that just why I can't exercise as much as I want to anymore? And just going back to exercise clearance, I think that's an important thing to evaluate just much more fully than saying, well, you're just 65 and not 40 anymore, and that kind of thing. So Sometimes that is the case, but when you, I think it's just all part of having a conversation with your patient that this might be something that's reasonable to try in somebody who's really had either a dramatic or abrupt change in their exercise tolerance, and not something that you would expect a little bit more commonly by somebody just having age-related or fitness-related decreases in their ability to exercise. As I think Dr. Harris is the first person to say this term to me, but the vanity VO2 Max testing, I think, is another place that we're going to get into quite a bit with our testing here. And this is talking about elite athletes, fitness optimization, and people who want to know, what is my VO2 max. People who want to know what their zones are for adequate training. And I think a little bit more time I'll spend on how can we design workouts for people with specific goals. So weight loss, fitness for endurance athletics, fitness for more sprint type athletics has a lot of application with the exercise testing that we can do, and then tracking progress, and we'll talk about a bit too. So the first one is, what's my VO2 max? And this is a little graph or a little chart of what VO2 maxes are in an athletic population. And my favorite thing I've ever seen with this is when I was doing a couple of tests last year, a guy came in and had this chart on his printout from the year before. He had this chart, and he had his number written in red, and then he was on a cycling team, and he had all of his other cycling buddies listed on this graph. And so he wanted, Bob Williams was 5 points higher than him, and so he wanted to see, talk about whether it was possible for him to pass Bob or not on this chart. I thought that was like the quintessential vanity VO2 max testing, but it's a reality. It really is, and so especially in these cycling teams or elite master athletes or even elite professional athletes, I think it's important for them to know their VO2 max, and they want to be able to improve it and increase it, and that service is something that we can certainly provide, and we can help them catch Bob Williams and Mark Harris, who I'm sure is in the elite endurance category of all of this stuff. So that's a very bragging rights type of thing, a vanity type of thing, but something that people desire and want, and something that we can do in our world. The other that I'm going to try and spend most time on here is training in zones. And so this pulled from, this representation is pulled from, a slide on heart rate zones, and which is using 220 minus your age for your maximum heart rate, and where you should fall in terms of heart rate monitoring while you exercise to be in these anaerobic versus aerobic weight loss light exercise zones. And both, I think, for people who are elite athletes trying to train for things, as well as people who are trying to design an exercise regimen that fits their needs best. And I think specifically the weight loss type of world, I think CPET testing can play a helpful role in designing these types of zones and exercise regimens. When some of the people that we would see as I was doing my training, this would be people who would come in, they're exercising like crazy, but they're not losing any weight. They want to know, is there any way we can help them with our CPET testing, the guidance we can give people with their zones to help them lose weight. And what we'd see a lot of times is that they were exercising in a aerobic to spiking into anaerobic zone, and that might not be the best way for them to be exercising if weight loss is purely their goal. When the elite athletes come in, they want to know, how much time can I spend in my maximal heart rate zone? How much time should I spend in my recovery zone? Things like that. And I think that's all important, but a little bit more important, or globally important, I guess, is talking about the fitness optimization. So weight loss, again, is an important one. So if you're an endurance athlete versus a more trained athlete who wants to lose some weight versus somebody who's just kind of sedentary and trying to lose some weight, we can give you much different guidance in terms of your CPET, based on your CPET results, about where you should be spending your heart rate or your exercise time in terms of your heart rate. And again, going back to our VO2 max, our anaerobic threshold is related to its maximal heart rate. A lot of these graphs that we have are based on heart rate, and when we can say that your anaerobic threshold is 60% of your maximal heart rate versus 80 or 85% of your maximal heart rate, it's going to change a lot where you're going to have these zones to be able to exercise in and participate. And for different goals. So if your goal is weight loss, we can give you a much different set of parameters than if your goal is training for an endurance walking event or a marathon, half marathon or something like that, versus training at a different level, whether it's elite or not, for sprinting type of exercises or hill climbs or mountain climbs. And I think this is to me, probably in terms of my world and what I hope to do, the most interesting place to kind of live and work in the CPET world is how can we help people achieve a goal based on the thresholds that we see or the zones that we see with our CPET testing. The last thing to talk, or a couple more things to talk about, is our tracking of our progress. And so this can be one method or one area in which we track progress. It is an interesting one because your ability to change your VO2 max is relatively limited compared to your ability to run farther or lose weight or lift more weight or something. It's probably only about a 15% increase in your VO2 max just based on your genetics and your ability to change that. And so, because as I was in the book here, you can get off the couch and run a half marathon, but you probably can't get off the couch and be an elite Swedish cross-country or cross-country skier, yeah. Which I think is important to let people know about. And so when we come in and they want to have a huge jump in their VO2 max, that's something we need to just be able to counsel people about and make sure that we're not setting undue expectations on folks. An area, as we sit in this room, and we talk a lot about cardiac disease, and I'm not going to spend much time on this because I think it's a complex and complicated world that it's not something we're going to get into right away. But there are, in cardiac disease, things like hypertrophic cardiomyopathy, differentiation between cardiac disease and physiological remodeling of the heart with athletics can also have implications, or we can see CPET implications in that as well. But we really want to see, is there a change in their VO2 max relative to their predicted? Is there a change in their maximal heart rate relative to their predicted? And we may eventually get into this, although again, I think it's something that's a little bit down the road for us. So I was sent an email a couple of weeks ago by Dr. Dresner. It's at the bottom there, which I loved, because it was like this incredibly expensive metabolic cart that's come into the sports medicine system. And they sent like an Amazon, your order is shipped email to Dr. Dresner, which I thought would just crack me up. And I was wondering if I was getting it with a book and a wedding plate or something like that. We're going to have a metabolic cart and a CPET testing capabilities at the new sports medicine center that myself and several of us are going to be running. And I think a lot of this talk for me was helping to frame my understanding of how we're going to do CPET testing at the sports medicine clinic, and hopefully I reflected that a little bit, particularly in the applications to sports medicine. We're happy and would love to see folks there anytime anybody has any interest in that, counseling them both on testing for exercise exertional types of symptoms as well as guidance for fitness and exercise. That's all. Questions from anybody?
You mentioned that it would be, you only really have a 10-15% sort of flexibility in how much you can increase your VO2 max. And I was curious how much of that is age dependent. If some parent comes in with their kid and says, hey, I want my kid to have the best VO2 max possible, and I want to be her to be an elite athlete in some parameter such. Is there more modifiable factors early in life? Or that's a sort of a genetic set point?
My understanding is that's more of a genetic set point. And do you know? Yeah, I think that's just kind of how you're built and what you are. And I think as we counsel people, and I think it probably is very similar to other ways we think about that, right? So the person who's 14 and is barely playing on their high school or junior high baseball team is probably not going to win a Cy Young someday. And the same kind of thing happens with this type of testing too. And I think even more so we see it in an older adult population where people come in and I gotta win that Colorado mountaintop road race, and they're riding there. They get smoked on the brick, So I think it's tough to. This comes back to our art of counseling, and I do think we have to think about that a little bit as we start to do these kind of testing just to know what your VO2 max is that the terminology used in the scales or those charts in terms of where you fall in a relative to other people who are athletes. Right? And so if you notice, I can go back to it, but this one that I use, it's from some of the stuff I did last year, and you can make those terms whatever you want, right? So like only the bottom two are negative in connotation, so like below 30 is poor and 30 to 32 is fair. Everything else has a really positive connotation to it, like good and great and super elite and expert masters. Well, so when we start to do that, I think we have to be careful a little bit in terms of how we both counsel people in terms of what this means. So if somebody comes in and they think they're an incredibly high-end athlete and they get a VO2 max in the 30s, I mean, how much does that matter? How do we counsel people based on that? And I think it's a lot more can we help to optimize how you perform and how you train versus exclusively what that number is. And I think that's something we have to be a little bit careful about and watch out for and set up those expectations ahead of time too.
Sort of along those lines, one of my patients is in the league throughout and all sorts of weird things and stuff and everything, and I asked him what's the newest VO2 max, and he said, I don't want it.
Yeah.
He's like, if it's low, what do I do?
Right.
He's like, you're gonna freak me out.
Right. And they and the people that very similar people that we saw too who came in, and I've seen these people last year when they come in and they get their VO2 max and they are so mad. They're so mad at themselves, and then from a business model perspective, there's some attractiveness to that. So these guys will come back every 2 or 3 months. They want to know if they're increasing their VO2 max, and then are you more fit? I mean, you've lost a bunch of weight, you're riding a lot farther, but really the potential of your VO2 max increase is not that good. You just dropped $600, dude.
On that topic of serial testing, there might be another indication that we kind of get for overtraining symptoms. This is such a nebulous diagnosis, it's very difficult to really get any specific diagnostic criteria for a lot of these endurance athletes that are on these very intensive training. It's testing them at one point and then testing them again at another point, particularly when they aren't performing well, maybe another data point to be able to help us kind of make the diagnosis. We're placing the brain house with our athletes here.
Yeah, I totally agree. I think that it kind of crosses over between that athlete evaluation and then some of these symptom change evaluations, right? And why are you having this decrease in your tolerance and what's going on? I think that's a great application of it.
I think that's where that really the rational is. There's definitely a heritability to trainability and to the VO2 max. So it's really what the parents gave you affects your VO2 max. People don't know that. And I think the other thing is when people talk about increases you get in the VO2 max with training, the data that was used to generate that is by taking fit people, maybe
So, so our next lecture is going to be given by Dr. Monique Burton. Monique's been a long-time member of our family here in sports medicine. She's the director of the sports medicine program at Seattle Children's Hospital and assistant clinical professor there in the Department of Pediatrics as well as the Departments of Orthopaedics and Sports Med. She deals a lot with a group of athletes and individuals that I basically never see. And she'll be talking about idiopathic adolescent scoliosis. So welcome, Monique.
Thank you. Okay, well, I feel a little bit weird giving this talk when Tom's sitting right there, and he's an expert at all of this, but I'll try to make him proud. All right, so we're going to talk about adolescent idiopathic scoliosis. So the definition of scoliosis is that there's a lateral curvature of the spine. It's greater than 10 degrees on radiograph, and it's typically associated with some rotation. So there's 3 different types of scoliosis. There's congenital, there's idiopathic, and there's neuromuscular. And we're going to talk about idiopathic scoliosis, and in particular adolescent idiopathic scoliosis. So the types of idiopathic scoliosis that we see, that we think about, are infantile, which is less than 3 years of age, juvenile, which is the children that are between 3 and 10 years of age, and then the adolescents, which are skeletally immature people that are over 10 years of age. And this is mostly what I see in my clinic. The ones that are younger than that, Tom sees. So, okay, so in scoliosis, there's about 2 to 4% of children that are between the ages of 10 and 16 that have some degree of spinal curvature. So there's a small amount of people that will just notice, and some people, obviously, they aren't ever even diagnosed, but if you were to look at them when they're at the beach or swimming, you might notice that there's a small curvature that was never even brought to anyone's attention because it wasn't such a big deal. The prevalence of curves that are greater than 30 degrees is pretty small, so about 0.2%, and those that are greater than 40 degrees is even smaller, about less than 0.1%. So a very small amount of people actually have curves that are significant enough that end up needing some type of possible intervention. The small magnitude curves are equal between boys and girls, but when they get larger, they tend to be more common in girls by 4 to 1. So the etiology is a little bit unclear, and I'd say this is one of the most common questions that I get asked by my patients, the families, is why does my child have scoliosis? And we don't know completely why they have that. We think that it's multifactorial, for sure, and we think that genetics plays certainly a role in scoliosis. So the specific mode of inheritance we still don't totally understand. But when they've done twin studies, they've seen that there's been a high concordance rate against those that were monozygous as opposed to those that were dizygous. There's other things that we think factor into that, certainly connective tissue issues, neuromotor systems, biomechanics, hormonal systems, but none of these have been really proven yet to be exactly a cause, but we think they probably do have some contribution towards scoliosis. So it's important to understand the natural history of scoliosis when you're talking to your patients because it allows you to be able to have that conversation about the expectations or the things that we'll be looking for to understand if the curve might progress or not. So those things that we look at are the future growth potential, their gender, their curvature severity at onset, and the curve pattern that they have. And we'll talk a little bit more about each one of those things. So as far as future growth potential, we know that curves are more likely to progress during that time of growth. So during the time of puberty, they're more likely to have the opportunity to progress. So that's certainly something we want to be aware of when we're looking at our patients. The things that we really look at is their menarche status. So we know for females, that's a good way to indicate of where they kind of are in their pubertal status and where we can kind of expect their rapid growth to occur. The age of the patient at their onset, how much time do they have in their life to have this curve that may have the potential to change. So the younger they are, the more closely and the longer you're going to watch that because their opportunity for the curve to change is a longer period of time. And something called the Risser sign that we're going to talk a little bit more about. So here's the Risser sign, and it's a measurement of skeletal maturity, and something that probably you've seen a lot when you're doing your spine films on adolescent people, but not necessarily looking at their iliac crest for this reason. We know there's an apophysis there, and probably for all of us in sports medicine, we are more concerned about the apophysis for other reasons, but this is something that we use to help us to identify potential growth in the future. So the ossification of the iliac crest begins at the lateral aspect, and then it moves more medially. And that allows us to monitor the potential for growth based off of a Risser sign. So when we're looking at the Risser sign, we take the iliac crest and we divide it into 4 sections, and then we label them as 1, 2, 3, 4. And then when it's completely fused, meaning that you actually just don't even see that rim of ossification anymore, then that's a 5. So the Risser 1 would be up to 25%, 2 up to 50%, 3 75, and 4 100. So the reason it's important is because we can use it to have an assessment of skeletal maturity. We know that people who are less than or equal to Risser 2 still have about 3 times the risk of a curve progression. So it allows us to know that that's something we still want to be following. When people are Risser 2 and premenarchal, 50% of those actually there's a 50% curve progression risk, as opposed to when they're postmenarchal, that decreases to less than 20%. So this is actually more for girls than for boys, but we're looking at the Risser score to be able to evaluate that. And you can kind of see that a little bit better, hopefully, on this one. You kind of see that rim of ossification along that iliac crest right there. So now you'll look for it when you get your spine films, out of curiosity. All right, the other thing we look at is curve severity. And then so when we're looking at curve severity, it gives us an assessment of the curve progression risk as well. And again, we are always looking, are they skeletally immature or are they skeletally mature, to be able to make a distinction about that curve progression. So in the skeletally immature, a 20-degree curvature has about 20% risk of curve progression, 30-degree, 60, and 50-degree and 90% risk. And so obviously, the bigger that the curve gets, the more risky it is to progress. In the skeletally mature, a little bit different. So if their curve is less than 30 degrees, then they're not likely to progress that much into adulthood. If their curve is 30 to 50, then they actually have about a 10 to 15 degree progression, and greater than 50, about 1 to 2 degrees annually. So again, those bigger curves are something that even if they are skeletally mature, if they get to that point, then they have the risk of progressing, and they're more concerning in that extent for their adulthood. When we look at the curve, the other thing we look at is curve patterns. And so the typical curve that we'll see in our adolescents is that thoracolumbar curve. That's the most common. It looks like that S-shaped curve, I think the most common thing that we identify. The higher risk curves and the highest one is the double thoracic curve, so the higher up curves. They're harder to do anything about from a bracing perspective, and they're less common. The lumbar curves have the lowest risk of progression. So if someone just has an isolated lumbar curve, it's less risky. So screening, that's kind of always the magical question. I think of screening in this population is that when you are doing a pre-participation physical examination and you're doing all of your other things that you're doing, and when you're doing your musculoskeletal evaluation, you might just observe if somebody, when they're leaning forward, has some unevenness in the shoulders, and we'll talk a little bit about what we're looking for on the screening. But it is an opportunity for us to look, especially in those younger athletes, since that may be your point of contact with them. So as far as universal screening, it's still very controversial. In the United States, the USPSTF in 1996 actually said that there was insufficient evidence to recommend for or against it. In 2004, they actually recommended against it. However, in 2008, some of the larger orthopedic and scoliosis organizations and pediatric organizations got together, and they felt like although there's limitations, there's potential benefits that patients may receive from getting the screenings for those ones that you get. And so they recommended that females are screened at 2 places, when they're 10 and when they're 12, and that males are screened once when they're 13 or 14. And that just speaks to the difference as far as when people tend to go through puberty, but an opportunity for you to be able to check in and see if they have that. Screening's pretty simple, and so it's not something that's challenging to do, and especially for us when we're having that point of contact for sports. So how do you screen? Well, there's several different ways. From a more mass screening perspective, you certainly are doing something that's not a radiographic finding, but these are different ways, and we'll talk about each one a little bit more. So the Adams forward bend test is a really easy way, and we'll go over that. Using a scoliometer, which basically looks like a little level, and then certainly evaluating the Cobb angle in more detail as a way to really get a look at the degree of curvature. So when evaluating somebody for scoliosis, they may present to you for many different reasons. I think one of the most common reasons that I feel like I see a lot of people in the summer because they're in tank tops, they're in their swimsuit, and their parents look and they go, oh my gosh, like where did that curve come from? And it could have been, probably was there for a little bit longer than that. But that's a common reason that I'll see, or sometimes from family friends or from other athletes if they're swimmers or some sport where they're not wearing clothes fully cover them, then their friends may notice that they have a bit of a curvature. And certainly we have the opportunity to evaluate them when they come in again for their physical examinations. So in evaluating for someone for scoliosis, the kind of highlights of the questions in their history that I like to ask them are when did they notice the curvature? So most often it's just prior to when they present to you, but I certainly have had people who have told me that they've noticed it for a while, but they didn't think it was a big deal, or they've been being followed outside. So noting the age at the onset of the curvature being first noticed. A family history. So again, thinking that genetics plays a role in scoliosis, then you do want to ask about any scoliosis in the family and how severe it was. Was it somebody that needed to go on to have surgery? Did they have to have a brace? Or is it just an incidental finding? And who was that family member that had scoliosis? The menarchal status for females, and as we know, definitely an indicator of our pubertal growth spurt. And then pain, something that you want to observe, and we'll talk a little bit more about that. Pain is not usually a presenting sign of scoliosis, so it's something that we need to take more seriously. And certainly if they have any neurological changes, hopefully they would have gotten to you for that reason before just evaluating scoliosis, but you do want to make sure to ask those questions. The other thing I do ask is about parental height, and not that that's an absolute predictor, but if you have very tall parents and you have a shorter patient that you're evaluating, then you also know that there's that potential growth as well. So as far as back pain, that's not a typical presentation of scoliosis. So if you see somebody and they're presenting to you for back pain and, oh, by the way, I think it's because I have scoliosis, then you need to investigate further. It's probably not the scoliosis that is the reason for their back pain. So but when they did a study of over 2,000 patients, 23% of them had back pain at the presentation, and another 9% developed back pain during that observation period of time. But 9% of those patients actually had an underlying other condition. And of course, of us in sports medicine, we're always thinking about things like a spondy. So when you have a patient that comes to you with back pain and they otherwise were somebody you evaluate for spondylolysis, then that's still going to be the thing you evaluate for, and scoliosis as well. And other things that are certainly more concerning can be observed as well. So on your examination, the things that you want to make sure to highlight are getting their height. And you want to make sure to get a height at every visit that they come so that you're noticing that the time where they're having changes in their height and being able to anticipate that time of height progression and noticing if it slows down. As far as skin, you want to look to see if there's any midline abnormalities. So there may be a midline abnormality that could indicate that there's some underlying other pathology. So certainly observing for those things, and that means, of course, that you're getting your patient in a gown and short, so you have the opportunity to really see their entire body. So when you do your visual inspection, you're going to notice things like an unevenness in their shoulders. You might notice a difference in the way that their scapula protrude, some changes in the way that their flank hip creases are, and from the front side, and this has actually been a presenting complaint to one of my patients, that they noticed that they were having unevenness of their breast. And we're obviously very concerned about that, and then you turn them around and it's actually due to their scoliosis and the curvature there. If they have a true leg length discrepancy, then that obviously can make a difference and make them have a perceived scoliosis when it actually is a leg length discrepancy. So evaluating for that, and if they have that, putting a block underneath their foot at the appropriate height so that you can even them out and see if they still have the curvature there. And Tanner stage, more of a general assessment of their place in where they are in puberty. You want to always do a neurological exam, so looking at their strength, their balance, and their reflexes. The other reflex that I include in an evaluation for scoliosis is the abdominal reflex. And the abdominal reflex is done when the patient is laying supine, and you take the other side of the reflex hammer can be a good thing to use, and you simply stroke the abdominal area in the midline just on either side above and below the umbilicus, and you'll see the abdominal musculature contract towards that side, that's a normal reflex. If they don't have that, then you may need to be concerned that there's some type of interspinal pathology. So a nice thing to add to your evaluation. I call it for my patients the tickle reflex. And so the other thing the big thing that we'll do for screening is the Adams Ford bend test. And this is a great thing to do because it's a consistent thing that you can do at every visit that you do, in addition with the scoliometer, which we'll talk about in a second, allows you to monitor in a non-invasive way in the sense of not having a radiograph. So the Adams Ford bend test is done by having the patient stand with their feet parallel. Then they lean forward until their spine is about horizontal with the ground. Hopefully they can get to horizontal with the ground. And when you look at them, you're able to observe and see if there's any changes in their contour. So for example, in this little girl, you would notice that there's some change in height when you look at them. And it's a really pretty good way to be able to see. And this is something that often the families will tell you, that the parent was looking at their child and they leaned forward and then they said, oh my gosh, they have like some unevenness, and they noticed that one side of their body was higher. So they may have done some pre-screening for you in that sense. Using the scoliometer to be able to follow your patient is a really good tool. So the scoliometer really does look like a little level. I always show my patients to let them know what I'm going to be using on their back so that they're not alarmed when they're kind of putting something there, and letting them know obviously it's not painful. It allows you to measure some vertical rotation. And so the way that you use the scoliometer is that you have them in that Adams Ford bend test position. You take the scoliometer and run it along the spine. So it's on either side of your spine and that little kind of curved part here. And then you move it along the spine and you note the place where you have your biggest change. And so there's little markers on here that allow you to have numbers to follow, and we'll talk about those numbers a little bit more in a little bit. But it allows you to have a marker and it's something that you can observe over time. So radiographs are not necessary in every patient, and we'll talk about some of the parameters for that a little bit more in detail. But indications for radiographs would be that if they have an obvious significant curvature, we do use other parameters, but if they have a really big curvature, then they're probably going to be somebody that you need to have a radiograph on. But the scoliometer is a very useful tool. If they have a measurement that is equal to or greater than 7 when you do that tilting look, then that is somebody that you would recommend to have a radiograph on so that you can see what their Cobb angle is. The Cobb angle is something we'll talk about in just a little bit, but the Cobb angle and the scoliometer degree are not the same. And so when you're looking at the degree on scoliometer and trying to give somebody an idea of what the radiographic curvature is going to be, those are different, and there's not an equation to compare those. So you certainly want to make sure you're distinguishing the scoliometer versus Cobb angle measurement when you're talking about it in your reports. Also, if in somebody that you're monitoring for scoliosis and they're noticing a big change in their curvature when you're coming in for using the scoliometry measurement, that's somebody that would also lead you to want to do a radiograph. And certainly there are people who just change to the point where they need to have a new radiograph because their curve gets bigger. So looking at radiographs, the first time that we do a radiograph, we do an AP view, but after that we do a PA just to minimize the radiation exposure, since these are people that you're going to follow on a regular basis, and certainly that's a concern of the family that you're doing a lot of serial radiographs, so making sure you minimize that. You'll do a PA view subsequently and then a lateral view. It's very important that you have them standing, because if you have them laying down, that's going to change the appearance of the curvature and not give you an accurate assessment of the measurement. So make sure they're always standing up to do this curvature. And we call it a scoliosis view, so you're getting that entire view of the spine, and preferably done in that way as opposed to piecing together different sections of like a thoracic and a lumbar film. That's not an ideal way to do it. Again, if they have a leg length discrepancy, you would want to correct for that, because that's going to affect the appearance of the curvature. It's going to affect the degree of the curvature and possibly falsely give you a larger curve than you actually have. So looking at curves, and to be able to learn to describe your curves on the radiograph, you're viewing it so the heart is on the left side so that you can speak to it and you can look at it and realize exactly the direction of the curve. And you're describing the curve by the direction of the convexity points at the location of the apex of the reference. And so again, the most common curve that we're going to see in an adolescent is that double curve, and there's most commonly a right thoracic and a left lumbar curve. So when we're looking here, you have your right thoracic curvature, your left lumbar, and another thing that you want to note is the Risser sign. So down there again is that Risser sign, and this person ends up being about a Risser of 2 because they're halfway across that iliac crest. If you see somebody who has a leftward curvature, that's something that you want to investigate further. That's not common, and it can indicate that there's something else going on. And so those patients are ones that we often do something more investigative. You also want to look for other things. So sometimes when you do these radiographs, you'll find that they have something like a hemivertebrae or some type of other vertebral anomaly, which may actually be the reason that they have the curvature, because the curve is bending because of that abnormal vertebrae. So to calculate the Cobb angle, fortunately, I think all of us who have PACs are able to do this a little bit more easily than actually getting out your radiograph, drawing the lines, and drawing your perpendicular line. But technically, what's occurring when you do that Cobb angle measurement is you're looking on that upright view, the PA view. You're finding the most tilted vertebrae that's above and below the apex of the curvature. So over here, lost my pointer, where you're looking at the top portion of the upper vertebrae and the lower end plate of the bottom vertebrae, and then there's a perpendicular line that's drawn at each of those, and then that angle gives you the amount of curvature. And again, so if you have PACs conveniently, you just locate the most tilted vertebrae above and below the apex of that curvature, and when you place those lines on there, it gives you the Cobb angle rather than you having to draw these other more fancy lines. So nice that we have that ability on our PAC system. There is obviously some change, and there's obviously some reliability issues. So we always give people about a 2 to 3 different discrepancy, because if I were to measure and Tom were to measure, we probably are going to get 2 different things, but they'll be pretty close together. But letting the families know, because if you get 20 and the other person got 22, that's pretty much the same, but to them that may be significant and they may feel like the curve is progressing, so letting them know that's within that range of inter-rater reliability. So other imaging we don't usually do, but if you do have somebody that has that left direction curve, if they're having significant or unusual pain, any other type of neurological findings, or other concerning radiographic findings, say you see some very abnormal vertebrae, then that would be somebody that you'd also want to do. And then certainly if somebody has a concerning history and physical, something that comes up when they're evaluating them, then that's another person that you would want to evaluate. So bringing this to our management, the goal is to prevent the curve from progressing further. So this is actually sometimes a very challenging thing for the families to understand, because when they see you, they want you to make that curve better. They want it to go away. And the important conversation that you're having with them is that we're not trying to make the curve go away. We're glad they came in so that now we can monitor it and hopefully prevent it from progressing further or to a point where it would be in a concerning range. It's not very satisfying though for a lot of people. So your plan for your management is based on their severity of the curve at their presentation, the pattern and location of the curvature, and their growth potential. So again, looking at their chronological age, their menarchal status, and their Risser sign. So the majority of the adolescents that you screen are not going to require any intervention. A very small number of them are actually going to need some other type of management. We'll talk about those options. So the options are going to be observation, and that is the most common thing when I see my patients with scoliosis. I'd say the majority of patients that I truly see are people who have come in who actually are very near their menarche or beyond that, and so we're actually just observing it over time, making sure that it doesn't change. But there's some non-surgical interventions, and then there's also obviously the surgical interventions. So we divide our management into looking at those patients who are skeletally immature and those who are skeletally mature, because it makes a difference for how you're going to follow them. So in the skeletally immature, we're watching them because obviously they have that risk of more curve progression. And I have a little flow sheet on the next slide. But the first thing that you use is that Adams forward bend test and then your scoliometry measurement. So if they're less than 7, then you can just monitor them. You don't actually need to do a radiograph at that point in time, but you're monitoring them on a regular basis to see if they're going to have any change. So about every 6 months. If they're skeletally immature, if their scoliometry measurement is greater or equal to 7 degrees, then you are going to go ahead and do that radiograph, the upright PA and lateral radiograph. From the radiograph, you're measuring your Cobb angle, which we tend to use synonymously with the word curve. And so when you're getting curves that are less than 25, and they're in that range of Risser 0 to 2, so they're still skeletally immature, you're going to observe them every 3 to 6 months. The reason why they're potentially in that rapid growth phase, you want to make sure that you're catching any interval change in their curvature. If their curve changes more than 5 degrees in that interval that you see them, then you would want to consider other options like bracing. Also, if the curve gets greater than 25, you'd want to consider an option like bracing, which we'll talk about a little bit more. Those curves that are 25 to 40, there'd be a conversation about whether bracing would be appropriate for them. And curves that are greater than 45, then we're going on to talking about is the surgical intervention appropriate for them. Just a little flow sheet that has the same thing on there. You're looking through the scoliometer, you're observing depending on their changes. So when we move on to our skeletally mature patients, or patients who are not necessarily fully skeletally mature, but they're 2 years past their onset of their menarche, or their Risser 3 or higher for girls, and a little bit higher for boys, those are ones that you're going to also observe on a regular basis, but a little bit further out time. So if their Cobb angle is less than 25, it's okay to watch them about every 6 to 9 months. And you also want to monitor them about a year after their final skeletal maturity. After skeletal maturity, which are not necessarily ones that we see that often, but in our adolescents that present to you, I often have patients who have back pain that come to me who, oh, by the way, have scoliosis, and they're like 16 or 17-year-old females, so they've reached their skeletal maturity, but they also have this. So these are those patients that you're falling into that range of. So if their Cobb angle is less than 30, it's not likely to progress, and it's someone that you probably don't need to worry as much about their curvature. But those ones that are greater than 50, of course, I mean, those are pretty significant curve. Those are curves that can change in adulthood, and they're going to be you're going to want to monitor them in their adulthood life to make sure that they're not having progression of their curve. So other options for non-surgical management are the brace therapy, and that's probably the most common therapy that we are using for scoliosis curves that are in that above 25 range. So brace therapies, the goal is to prevent the curve progression. So important conversation again to have with the family that we're not necessarily going to change that curve to a smaller degree, but you're trying to prevent it from getting any larger. And the indications would be the patients that are, again, skeletally immature, and their curves are greater than 25, less than 40, so you're worrying when they get larger than that. Or if they have that progression of more than 5 degrees in that interval of observation. It's not indicated in patients who are skeletally mature because they're not likely to change, as we talked about. And then patients who are over 50, you want to have a different type of conversation about possible surgical intervention. They have to wear them a long time, so the majority of the day, so it's not necessarily the most fun thing for an adolescent or pre-adolescent female to be wearing, or male. They are, however, pretty streamlined, so when they have their clothing on and it's not the summer, you don't necessarily see it that well. They do custom make them so that they're contoured to their body, but obviously still something that makes people very self-conscious about that. They wear it the majority of the day, and they can take it off to do sports, which is nice. All of us in the room who are in sports medicine, it doesn't mean that it's a sentence for them not to be able to participate in sports activity. You want to watch them about every 6 months, and they're going to wear that until their peak growth has concluded. So that's for girls when they're about Risser 4 and 2 years past their menarche. And boys, it's longer because we think that they have changes beyond when their Risser is 2, so around Risser 5. The options for brace therapy, the most common is the Boston brace, the TLSO brace. Again, custom fit, it's better tolerated, it's easier to camouflage underneath their clothing. This is the brace I think that we all think of, like the dreaded brace of the cervical, thoracolumbar orthosis. That one is the Milwaukee brace, and it's for those patients who have those higher curves, the one that goes all the way up to their chin, and that's a lot harder one that people aren't going to tolerate very well, and not one that I've commonly used. As far as bracing therapy, other options, there's the night brace, and this is the Charleston or the Providence brace, and it's the goal is to have maximal side bending corrective force, and they wear it at nighttime. You can consider it in people who have that single curvature that's in that lower range. Those upper curvatures, this is not going to help. So it's pretty controversial, and there's recently been a study called the BRACE study, where it's looking at patients who were in their adolescence skeletally immature with those curves in the range of 20 to 40. And they did actually conclude from this study so far that those high-risk curves that are in that range of 20 to 40 possibly benefited from bracing, and so we've moved to having that conversation about using bracing. It's always an option for the family. If they don't want to do it, then it's not something they have to do, but it's something that we should have the conversation about it being a possibility for them. So other non-surgical options are physical therapy, chiropractor, biofeedback, and electrical stimulation. And the Schrock method is actually something that we're doing at Seattle Children's, and our physical therapists have been trained in to be able to do, and I'll tell you a little bit more about that. So the Schrock method was invented by Schroth, who invented it to treat her own scoliosis, and expanded onto other family members and other physicians in Germany and Spain, and became a method to try to actually prevent progression, and some people feel like maybe it could be a little bit corrective. So they're using cognitive, sensory motor, kinetic training to try to change the scoliosis curvature in the sense of making them more comfortable and hopefully not allowing it to progress. In a retrospective study, about 70% stabilized, 15% improved by greater than 5 degrees. So that's something that definitely the families are interested in. And then, of course, there were some that still progressed. So I think that it is a nice option to do. The goals are many. So one is to improve posture. I think, honestly, the goals and some of the expectations from the family is that they feel like they're doing something. It's a really hard conversation to have with the family that you're going to observe this curvature. Maybe they're going to try bracing, and that's all. I think that, especially somebody who's in sports medicine, we use physical therapy so much, we feel like we want to do something, and the families want to try to do something to help their child. And the something may be that they actually just feel better. And from our physical therapists, I've been told that they feel like their patients are having minimal progression, and some of them they actually feel like have had a little bit of improvement. So I think it's something definitely to consider. The criteria that we use for people to be considered are curves that are greater than 20, if they're 11 or older, and if they have a high-risk progression, and if they're skeletally immature. So certainly something that if you see, then you can have them seen for that as well. So surgical management, I won't talk about in much detail, but those are those curves that are higher risk. And again, you're not trying to totally correct the curve, you're trying to prevent the progression and achieve some type of maximal permanent correction, improve the appearance, which is certainly definitely relevant in somebody who has a significant curvature. The appearance is certainly a factor, and also hopefully minimize any type of associated short-term complications. So those are those bigger curvatures greater than about 45 degrees. And the other factors to consider, again, age, the curve progression, and if they have other symptoms. So if they're having pulmonary compromise, that's somebody that you want to certainly consider a surgical intervention, obviously for functional reasons. When the people are younger, there's a better chance of having a better outcome. So as you become more adult, your curve gets stiffer and it's harder to work with. So some people may want to wait until they're a little bit older because it is a big surgery to have. However, it's a conversation you want to have that there may be an appropriate time to do that to make sure that they have the best possible outcome. And we won't talk about exactly what they do, but there's been movement away from the Harrington hook rod system to pedicle screw instrumentation. And the thought is that it gets better 3-column mechanical fixation and it minimizes the number of levels that they have to fuse. And the other important thing that has changed in scoliosis surgery is that there's spinal cord monitoring, and that's a very good thing, obviously, to try to decrease the rate of neurological injury. So it's a much safer procedure than it was in the past. And so finally, again, adolescent idiopathic scoliosis is the most common form of scoliosis that we think the causes are multifactorial, and certainly an opportunity to screen for us on our PPEs or in your primary care clinics and your well child examinations. And your management of your curves is going to depend on those, depend on skeletal maturity and all those other factors we talked about. Thanks. unfortunately see the curves that are pretty minimal. So I counsel them that they can do anything and everything that they want to do. And so that is actually a concern. A lot of people will come in and say, now my kid can't do this sport anymore. And I said, that is not true. So usually it does not affect their ability to do whatever they want to do. Now those curves that are bigger, I actually usually refer on to our surgeons or to Tom, but those curves that are bigger are ones that if they're having any type of compromise, then those issues need to be addressed. But for me, I tell them they can do whatever they want to do. If they have pain and they think that it's a scoliosis, then I want them to come see me because it's probably not the scoliosis, it's probably some other back pain that we need to address. Do you have any other things that you tell them? Or Tom, do you have any other? I think minimizing the disease of scoliosis, I mean, I think that that's something that, I think we probably remember that from, or meaning me, who's of my age, remember like when we were younger and people had a brace on, and we're like, what is wrong with that kid? Like it was, I think that they almost got into this category of like, there's something wrong. And trying to really take that away from the patient and the family and letting them know there's nothing wrong with them. They don't have an illness, they don't have a disease. They can function completely normally and do whatever they want to do. And I think that's a really important message, that we have the opportunity to have that conversation with them so that they don't become the scoliosis and they don't have that be something that limits their ability to do what they want to do. And that's, I think, a really important part of our conversation and the conversation I have with them is that this should not affect their ability to do whatever they want. Yeah.
Do you generally see any reduced progression in kids that are more active, like more sports that take the weights off to do more things versus the kids that kind of embrace gravity and are more sedentary?
I personally haven't because I don't actually usually follow the kids that are in braces. I have our surgeons or Tom follow them. So I haven't seen that. I don't know, Tom, have you seen that at all?
Yeah, that's a good question. The question again is, if kids are more active, does that decrease your scoliosis progression? It's hard to sort that out because I think we would love to keep these active as we can, but I think just as Brian said, at the time of the brace is what we if your time of the brace is good and you're active, then you can use the problem. I can't we have to sort out the study. Perhaps once the study will put temperature sensors inside the brace and they monitor how many hours, also the hours that they were in the brace. There's also questions on that about how active you were, what you did. So there are many studies out there.
If you're applying brace, how much do you stress doing your core and metabolic stabilization when you're outside the brace as far as
So I would always, I mean, I think I'm in a biased place though because I'm always talking about core stabilization. So anybody who's having a complaint of pain, then certainly like as far as their therapy, then that's like a huge part of what we're asking them to do. I think actually with the Schroth method, and I don't just know if Whitney or Janet, you're not one of the Schroth partners, but they do a lot of movement and stabilization, and so I like it for that reason also because I think it gives the person who has scoliosis the opportunity to actually probably stabilize their core and their trunk better than they would have if they didn't have the scoliosis. You know, it's an opportunity for them maybe to really work on that. Yeah.
So the concern with the left thoracic curve, apart from just being anomalous in nature, is that regarded largely because of the heart or what?
Yeah, that is one of the things that we worry about, and there's also different. We worry about the interspinal problems, and mostly that's the things that we're looking at. I don't see them very often, but when we do them, we do actually do the total MRI, and we don't always find something, but it's something that you want to look for. I have had patients who've had known cardiac abnormalities have a leftward curvature kind of incidentally when we were looking for it. Any other comments, Tom?
If you have a thoracic spine curve, 95% of it is apex, right? So just by nature, it's so rare. And if you see an apex like curve, you can much more play with the spine line. Or for serious spinal curvature, or just not that
don't want left. Yeah.
I had an interesting presentation the other day. It was a patient who had a lot of signs of symptoms that looked like morphins, and he was going through the constant testing and all the cardiac workup. He does have some mild cardiopulmonary complaints, but they couldn't definitively say that he had morphins, but between T6 and the lower cervical spine was about 12 degree left apex curvature, so I thought that was something that's real for some people, which morphins. It seems random. It just when you mentioned that, I thought that's really interesting.
Marfan's curvatures are described. There's different descriptors of curvatures. Like for neurohormones, they call it dystrophic. Marfan's curves are actually described as complex because they sometimes have like 4 curves within the spine, and they can be sometimes small or subtle. And there's other things besides Marfan. There's something called Williams syndrome. There's other syndromes that are connective tissue disorders that we need to follow really closely because they don't have the cardiac issue, which is a great term about Marfan. You know that. But there's other connective tissue disorders. And one of them is Marfan's have, and the other ones will have, where the spine is called direct deviation. So that apex left curvature, and if he's a tall kid or has other signs of joint laxity, those are we're going to watch. Even if the great thing is cardiac's negative, then we're going to watch them and say, is it progressive? Are there other spine taking things? And they'll be ones that will be more pervasive over time. That didn't answer your question exactly.
No, that's
It's worth watching.
Yeah, I think that as you hear Tom talking, this is why for scoliosis, that I've gotten it to the things that I like, okay, these are the things that I know to look for. These are the things that are concerning. These are the things that are concerning that I'm going to refer to the people who have that expertise in them. And so I think that when you are evaluating scoliosis, knowing kind of the things that you need to be worried about gives you that opportunity to get them to the people who know what to do about the things you're worried about. But being able to manage those other expectations, I think, are helpful, especially all of us in sports. It's something that I'm sure you'll see.